Good morning, everyone. Good morning. Good morning. I'm super excited about being here, and I'm just so thankful to have this opportunity. The last couple of days have been really amazing, and I'm so thankful to have had that experience. Just before I start, I just wanted to acknowledge Dr. Harrison and just say what an amazing person she is, our immediate past president of AMWA. Can we give her a hand, please? I enjoyed our session just a little bit ago, and she really does epitomize what it means to mentor, but also, really importantly, what it means to sponsor, and so I really appreciate you for that. So I'm going to talk to you about achieving maternal and child health equity, and my particular interest, like Dr. Harrison said, is around Black infant mortality, and so I'll talk to you a little bit about that. I have no financial disclosures. 64,876. That's the number of infant lives we would have saved if we had eliminated the disparity in Black infant mortality between 1999 and 2013. So I'll tell you a little bit more about that story as we go along. But as I begin, I really want to leave two key points with you. And that is that the disparity in Black infant mortality is not inevitable. And number two, we can achieve health equity. So really quickly, we've talked a lot about equity, we've talked a lot about equality over the last couple of days. I'd like for you to just pair and share, so like reach out to someone at your table, get in your mind first, like what is the difference between equality and equity, and then talk to someone at your table for maybe just 30 seconds to share a little bit about that. So I'll give you a whirl to go. Okay, very good. So because of time, we'll come back together. So because of time, I won't have anybody share individually, but I did hear someone talking about the boxes and different people standing on the boxes, and I was thinking that that was a really good example. I'll show you this picture, which is very similar to that. So equality is about giving everybody the same thing, right? That's a good thing. We've talked about equality, we've talked about parity, and I think it was Dr. Bull on Friday, she said that parity is great and we need parity, but we also need power. And equity is about power. Equity is about valuing all people, and it's about providing resource according to need. So everybody doesn't get the same thing. Everybody gets what they need. And then I think the other thing that's important about equity is thinking about addressing institutional or systematic or historical injustices that have led us to a place of inequity. I wanted to just describe health equity a little bit. And when we think about the definition, I think we take for granted that everyone has a fair and just opportunity to be healthy. No obstacles, where they experience no obstacles to health, such as poverty or discrimination, or the consequences of those obstacles, like powerlessness, lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. And this really is the way that Robert Wood Johnson Foundation describes equity, health equity specifically. I think as we talk about health equity, it's important for us to remember the definition of health disparities and how health inequities, or that specific health difference, is related to and linked to social and economic or environmental disadvantage. And today I'm speaking mostly about racial and ethnic disparities, but it could come in any form, whether it's gender or where we live and our age and things like that. In addition, I wanted to point out the difference between health disparities and healthcare disparities. So in 2002, the Institute of Medicine wrote a report around healthcare disparities, and they talked about 3 levels of factors: patient-level factors, provider-level factors, and systems-level factors as it relates to disparities in healthcare. Healthcare disparities are about differential access in healthcare and services, as well as differential quality of healthcare. And specifically, the quality can be related to our uncertainty, like medical uncertainty, lack of inclusion in clinical trials or evidence-based medicine, and we've talked a lot about that over the last couple of days, and then discrimination, bias, and stereotyping that results in differential health outcomes. And those 3 areas in the middle there, they're specifically what we call provider-level factors. And I point that out because when we think about equity and we think about what can we do about equity and how can we achieve it, let's think about where is it that we need to focus our efforts, or where can we focus our efforts to see a change. Now we know that healthcare is super important for health, right? But we all know about the social determinants of health. As individuals, we have our biology, our genetics, who we are. And that impacts how we behave and kind of the lifestyle and behaviors that we are involved in. That's really influenced by our social and community connections, but all housed in this context of where we live, where we move, where we breathe, where we play. So access to good education, or housing, or clean food, or nutrition, or clean places to live, or nutritious food. And this is all impacted by this greater like socioeconomic, cultural, environmental conditions, sort of the social determinants of health. When I think about this big, broad scope of, yes, these upstream factors that impact our health, whether it's culture of economics or politics or religion, all of these things that impact our health, but they're not just impacting us as individuals at one moment in time, but like Dr. Penn said last night, these things impact us over the course of a lifespan. So when we talk about equity, we have to think about things in a life course perspective. I also wanted to point out stress and what happens over the life course. So I think when we think about disparities, we have to think about how stress impacts that. And we know that stress in the moment is good, right? Acute stress is helpful because it helps us react quickly. It's that fight or flight syndrome. But when we have chronic stress, we know that that's not good for us. We even know that there's studies that show that it shortens our telomeres or shortens our lifespan, those types of things. Dr. Michael Liu describes the difference or talks about reproductive potential and how that creates disparities and the stressors that occur over the lifespan. And what he says is that you have these differential factors. So someone who has more disparities or who has less equity as far as their health outcomes over the course of life is someone who has experienced more risk factors and less of the protective factors, if you will. You all might be familiar with some of the work by Shonikoff related to ACEs. Are you all familiar with ACEs? The CDC studies that talk about the trauma that people or kids experience and how that impacts their outcomes, even their choices, their behaviors, and risk for chronic disease and early death. So stress is really important. I think the bottom line is that stress too early is not good, too much of it, and chronic stress, okay? When we talk about stress, specifically as it relates to racial ethnic disparities, I think it's important for us to talk about racism as a stressor. And I really like the definition that Dr. Kamara Jones uses when she talks about racism. She describes it as a system, so not like an individual or person, but a system of structuring opportunities and assigning value based on how we describe people, based on the value that we place on how someone looks. So we know that race is a social construct, and how these things can unfairly disadvantage some, unfairly advantage others, and really sap the energy of all of us. I love the way that she uses the definition, and she uses like a tripartite definition. She describes it three ways. So she talks about that personally mediated racism, which a lot of people think about that when they think about racism. They think about someone interacting with you in a bad way that causes you stress individually. I'm sorry. And then there's this other racism that's internalized, so it impacts us and our health behaviors. And then the bigger picture of institutionalized racism, these systems and structures that we talk about that impact socioeconomic status or impact our access to health care. And I think when we talk about institutionalized racism, it could be institutionalized isms of other types, right? We talk about genderism and things that happen to us because of structured systems of inequity. So why does equity matter? Why is it that we care about this? Well, it's sort of a rhetorical question, but we know there's a moral and an economic imperative. So morally, it's just the right thing to do. Economically, we could save, I think the study in 2006, between 2003 and 2006 showed that we could save $1.24 trillion if we had eliminated the inequities and causes of premature death. So it's an important imperative. Let's speak really briefly about maternal mortality. So I'm going to talk a little bit about maternal mortality and then a little bit about infant mortality. And when I talk about maternal mortality, I thought about this morning, I said, well, maybe I'll share a personal story of someone that I know or someone that I'm really connected with. But I decided to choose a story of two women that I don't know, but whose stories impacted me. The first woman is Tamura Mcqueen Ceiba. And she was a 39-year-old African-American woman who had a postpartum hemorrhage, who nearly died. But she lived to tell the story. And because of her experience, because of her learning about postpartum hemorrhage and the maternal mortality rate, she became an advocate and started working as a maternal health advocate and even pushed for this act called the Preventing Maternal Deaths Act of 2017. It didn't pass yet, but she is working towards the advocacy. On the other hand, we have Dr. Shalone, who does not have the same story. Dr. Shalone was an epidemiologist, well-educated, nice social support system, lived in a nice home, had access to great health care. She even did health disparities research. She looked at ACEs and adverse childhood events and what happened to people over time. Unfortunately, she died 3 weeks postpartum to complications from hypertension. And you think about, we talk about disparities and we say, well, it's related to this and it's related to that. But the question is there something that could have been done so that she didn't become a statistic? This quote I found very impactful. It said, the researcher working to eradicate disparities in health, access, and outcomes had become a symbol of one of the most troublesome disparities for Black women as it relates to Black infant maternal mortality. Another quote that was in the paper that I read about her talked about, you know, if we had had as much diligence during the postpartum period as providers as we had during the prenatal period, maybe she would have had a different outcome. Maternal mortality, not just for Black women, but for all women in the United States is on the rise. And this sounds like kind of like, what, really? It's on the rise? And it's interesting because in the developing world, in developed countries, the maternal mortality rate has been decreasing, has decreased by almost 50%, whereas in the United States it's risen by almost 136%. And some people say, well, it's because we're measuring it differently and we're measuring better. But others believe it has to do with the obesity trends, it has to do with chronic disease, it has to do with women having babies when they're older and cesarean rates. We know that 50% of maternal mortality is preventable. 50% is preventable. And most of it's related to postpartum hemorrhage. The disparities, I want to highlight the disparities for Black women. The disparity is 3 to 4 times the mortality rate, 3 to 4 times. And it's thought to be related to higher chronic disease and higher case fatality. So for things like preeclampsia, for instance, or placental abruption, there's not necessarily a higher prevalence, but a higher fatality as it relates to those conditions. Some people have talked about what happens in the postpartum period, and is there something about the care that's happening in the postpartum period that's contributing to this? I also read a story, it's not necessarily about mortality, but more about morbidity, out of New York City, that showed that women, Black women were more likely to experience severe maternal morbidity, and they were also more likely to be cared for at hospitals where they had higher morbidity. So it's an interesting thing when we think about healthcare and how that healthcare is impacting our health outcomes. I bring this slide to bear because I think it's important for us to remember that while globally the maternal mortality rate is decreasing by 50%, we still have a lot of work to do. So you can see in the magenta, the fuchsia, the very dark pink areas, we still have quite a bit of work as it relates to addressing maternal mortality globally. Let's turn our attention to infant mortality. And I put all of these maps in the US on the slide together, just really to point out that we do have racial ethnic disparities, but also that we have disparities by region. And I'll just highlight the non-Black infant mortality rate, non-Hispanic Black infant mortality rate, which is 11.3, and this is data from 2013. And it's 2 to 3 times the non-Black infant mortality rate for most areas over the last several years, like years. And, but there is an interesting difference for American natives and Alaska natives where this discrepancy is not as great. So for them, it's 8.1. Globally, the trends in infant mortality are going down. And we also have some hope because the under 5 mortality globally has also decreased. So there is hope, and we're happy about that. I want to share a little bit about what we have happening here in the United States to bring us a little bit of hope as it relates to health equity and being able to achieve it. So that number, 64,876 that I shared for you at the very beginning, it is a number that came from this study. So I'm very blessed to have worked with one of my mentors, George Rust, and several other colleagues like Samantha Goldfarb and others on a paper that was published in the American Journal of Public Health last year on state-level progress, looking at the Black infant mortality rate and the disparity or the difference, the improving and what's happening in trends from 1999 to 2013. And what we found is that 13 states achieved statistically, I'm tongue-tied this morning, my mouth is dry too, significant reduction. But what I really found interesting, and I think is such a message of hope, is that 18 states would achieve infant mortality rate racial equality by the year of 2050, which many of us can see in our lifetimes if we stay along this trajectory. So my message is that inequities are not inevitable. And the bottom line is that we can achieve health. This is just a graph that shows all of the different states that we looked at. For the sake of time, I just want to share the bottom line is that we can make these differences, that we can see equality happen as it relates to outcomes if we turn our focus from determinants of health more towards determinants of progress. And we begin to think about not just defining the disparity and what's causing the disparity, because most of the times we kind of know where those inequities lie. It's more turning our attention to, can we study, can we look at these places, these exemplars who are doing well, and learn lessons, and then take that to a granular level and actually make some local and regional impact as it relates to health equity. So we can learn from exemplars. There's tons of exemplars that I could share with you, but I'd like to share with you one from my experience this past summer in Rwanda. This past year, I finished a fellowship for the Leaders for Health Equity Fellowship with George Washington University, and part of it was global. We had the opportunity to visit Rwanda, and it was just an amazing experience. Rwanda has made such recovery as it relates to outcomes, and I see some nods in the audience for people that may do global health. And I had the privilege to meet Dr. Agnes, who used to be the Minister of Health there. And I think yesterday someone was talking about the importance of women in leadership as it relates to inequities, and I really do think women in leadership are part of the reason that we've seen so much progress as it relates to Rwanda. Rwanda had to deal with so many different things: abject poverty, really severe burden of disease, and lack of access to care. But they were able to make a turnaround. And why is this? What can we learn from them? So in part, it was related to a relationship with partners in health and through the University of Global Health Equity. And what they did is they fostered leadership at every level in the health system. They established resilient institutions. They made decisions based on scientific evidence, and then they focused on providing care at the community level. And witnessing this in person was just really amazing, seeing the beauty of what they were doing, how they took contraceptive care down to the community level, community health workers doing contraceptive care, or nurses providing HIV care, and really seeing a turnaround and collaborating across sectors and being creative about how to address some of the social determinants of health. And what did they see? Increased life expectancy, decreased maternal mortality, decreased child mortality, increased deliveries in facilities in Rwanda. And with HIV treatment, of 79% of people with HIV on antiretroviral therapy, and look at that compared to the United States, and 58% that were virologically suppressed. So quite a feat, right? How did they do this? We talked about those 3 level of factors. I think they hit all of those patient, provider, and systems level factors. I think mostly this was a systems level issue, and that tells us a lot about where we need to focus our energy, but being able to address all these different levels is really important. I really wanted to turn our attention back to the United States really quickly as I'm getting close to closing, and just share with you this 12-point plan that was produced by Michael Liu that talked about closing the gap, the black-white infant mortality gap. And I think most of these 12 points are really related to improving healthcare access and systems kind of thing, and then improving health in general across the life course. And as women, we've talked about how can we improve our positions as women in academia and in medicine, those types of things. And some things we talked about were like supporting moms and families, and I think those are important as well as we talk about just decreasing disparities in health outcomes. Also, things like closing the education gap and undoing racism. There's 2 points that I want to make as it relates to things that we can do as individuals. So we talked about some systems things. We can also reduce bias and provide culturally responsive care. And I think you talked a lot about being empathetic and how you communicate with patients, which is super important. Very quickly, my stop sign's up, so I have to talk really fast. Bias reduction. This is work from Molly Carnes. A lot of people have talked about this, and Dr. Starr. It's an epic mnemonic. The mnemonic is engage in perspective taking, practice the right message, individuate, and challenge your stereotypes. And when you challenge your stereotypes, you have to know your stereotypes. So if you haven't done the implicit association test by Harvard, go ahead and take that. And then the crash mnemonic is culture, respect, assess, affirm, sensitivity, self-awareness, and humility. And I can share this stuff with you later since I'm going through it so quickly. But basically, it's about being aware of culture, being respectful of individuals, assessing for literacy and language differences and barriers, affirming an individual knowing that as a woman or as a man or whoever you are, you know you've had your lived experience. So affirm that for them. Being sensitive, being self-aware, know your own hot buttons and your own values and how that can impact your ability to communicate well with a patient. And then being humble, being aware that you can't be culturally competent. Like, I've had a cultural competency course, I've arrived, I'm done. Be a lifelong learner as it relates to this. My take-home points for you, let me just go to that really quickly, is that disparities are not inevitable. that we can engage in creative listening at the community level as being very vital. Take a multidisciplinary approach. We have to work together to do this. We need to investigate and apply evidence-based strategies as it relates to interventions, bias reduction, and then my take-home message for you, what I would ask of you, if you will, is that you obtain the data, know the data in your area, know what you're talking about. And then number two, value and love. I think so often we forget to talk about love. It's important to value all people, but then just love people and be loving. And I think that that helps us eliminate disparities and achieve health equity. We have to name and address isms. And I really appreciate that earlier, how we really named and called out some of the discrimination that happens. We have to name it and we have to address it head on. We can't just kind of scoot around it. And then fourthly, we're very powerful people. Use your own power and privilege to work together with those impacted by the problem to solve the problem. One of my favorite quotes is, our lives begin to end the day that we become silent about those things that matter. We have a voice. We can use our voice. And I would say that we can ignite change. Thank you so much.